Hello, can somebody confirm you can hear me?
We can hear you.
Thank you. How do I share my screen? There we go. All right, you should be seeing my screen. Of course, that's not a good screen to see, but before we begin, are there any questions? Not hearing anything. So today is October 23rd, and we're going to be doing Lab 6, Disk Diffusion and Antibiotics. Let me remind you that I will be sending you your unknown number and then the results for your first three tests on Tuesday. It'll probably be Tuesday after this lab. So, um, excuse me. Um, it may not be until late Tuesday night. All right. Any questions about what we're doing? I don't think I need that, so I'm going to shut it down. Didn't know I made changes. All right. Get that out of the way. Lab 6, disk diffusion, evaluation of disinfectants and antiseptics, and antibiotic effectiveness. There is some reading to all the labs. So read about terminology of microbiological control on page 177. Use about the principles of effective disinfection, evaluation, and evaluating an effective disinfectant, and then the types, page 187 to 194. Read about chemical methods of microbial control, pages 196 to 197. Read about antibacterial drugs, also called antibiotics, page 554 to 550. And then take a look at the test to guide chemotherapy and the disk diffusion method, also called the Kirby-Bayer method, on page 567 to 569. There are some video clips in today's lab, and there is a virtual lab. So the learning objectives for this lab, one, be able to identify the type of chemical agent and the active ingredient used in various disinfectants or antiseptics. Two, evaluate the effectiveness of disinfectants and or antiseptics using the disk diffusion method. Remember, the disk diffusion method is also called the Kirby-Bayer method. Three, determine the mode of action of various antibiotics. Four, evaluate the effectiveness of various antibiotics using the disk diffusion method. Five, list variables that influence antibiotic disk diffusion susceptibility testing. And then six, define the terms sterilization, disinfection, what's a disinfectant, an antiseptic, a bactericidal agent, a bacteriostatic agent, an antibiotic, what's a spread plate, and what is a zone of inhibition. Any questions about any of this? All right. Sterilization refers to the elimination of all viable organisms, including endospores. Let me, yeah, I probably won't get any more mail, but I got my mail open. That's what that noise came from. So when you sterilize something, all viable organisms are removed. In the microbiology lab, how we sterilize most things is we put it in an autoclave, which does destroy endospores. Disinfection refers to the destruction of vegetative cells, but not necessarily endospores. When we disinfect a toilet, for example, you're killing the vegetative bacteria, but you are not killing many of the endospores. Disinfectants are chemical agents applied to inanimate objects while an antiseptic is a chemical agent applied to living tissue. You can rarely have a disinfectant the same as an antiseptic. Like, for example, if I use the bleach to clean the toilet, I'm using it as a disinfectant. But if I were to use bleach on a cat to clean its wound, I would use it as an antiseptic. Usually, an antiseptic is less harmful to living tissue than a disinfectant. So that's why a bleach is not usually used as an antiseptic. But there is at least one exception that I know of, and that is when a patient, at least initially, when necrotizing fasciitis was first being treated, they would put the patient's gauze and band-aids and whatever you call that, the stuffing, they would put it in a bleach solution and then put that on the necrotizing fasciitis. And that would be actually bleach. The reason was is that the bleach would do less harm to the patient than the necrotizing fasciitis. And it was an effective treatment for necrotizing fasciitis. If you don't know what necrotizing fasciitis is, that is the flesh-eating bacteria. So normally a disinfectant is a little more harsh. We don't usually use them as an antiseptic, and bleach is an example. An antiseptic is less harsh on living tissue, like tincture of iodine does not harm, or at least our skin, and it is an antiseptic. To evaluate the effectiveness of chemical agents, the surface of a nutrient agar plate is first inoculated with a particular bacterium, and you get the bacteria to grow everywhere on the plate. Then, after inoculating the bacteria, but before you grow the bacteria up, you put paper discs saturated with different chemicals onto the surface of the agar. The chemical agent will diffuse into the surrounding agar, establishing a concentration gradient around the disc. You then incubate the plate at 35 degrees C. In the lab, we did it for overnight, but in reality, it should be 16 to 18 hours. And then the bacterial growth around the plate is observed. If a zone of inhibition is seen, an area with no bacterial growth around the disc, then the chemical is assumed to be effective for that particular bacterium. However, if there is no zone of inhibition around the disc, the chemical is assumed to be ineffective. Any questions about any of that? Note, I haven't talked about whether the bacteria is sensitive to the chemical or resistant to it. I've only said whether the chemical is effective or not. So this table 6.1 is listing the common disinfectants and antiseptics with the disinfectant or antiseptic in this table, and then the preferred use in the third table. Ethanol and isopropanol are very weak antiseptic or disinfectants, and we tend to call them de-germing agents because they really do not act as an antiseptic, removing most living cells from the skin. They do remove most, I should say, almost all living cells from the skin. They're not strong enough. They just reduce the number of microbes to an acceptable level why we de-germ with alcohol before we give a needle injection to reduce the number of microbes to a safe level. And then if you poke the skin, so few microbes are put inside the skin that the immune system can handle it and remove the microbes. Any question about that? So ethanol and isopropanol are very weak, and that's why we call them de-germing agents. Aldehydes, formaldehyde, formalin, glutaraldehyde are much stronger disinfectants, and they're so good of a disinfectant that they're one of the few disinfectants that actually can kill endospores. There's only one other disinfectant that can kill endospores, and that's a peroxygen, such as hydrogen peroxide. when you apply hydrogen peroxide to living things, it can kill cells by oxidation. And hydrogen peroxide is a very good antiseptic because it kills endospores, which isn't stated here, but I'm telling you. And then formalin and formaldehyde are very good disinfectants. They kill endospores, but these substances would be toxic to skin. So we use them as a disinfectant, not as an antiseptic. Halogens, like tincture of iodine, chlorine bleach, are halogens. They're very good antiseptics for tincture of iodine and a very good disinfectant for chlorine. But once again, most disinfectants or antiseptics do not kill endospores, at least most endospores. Heavy metals like mercury and silver were not used for a while by the medical industry because heavy metals are toxic to humans. However, their use has come back because of the resistance of microbes to treatments, including antibiotics as well as antiseptics. And so, what they do is when a patient gets gauze or a very thick band aid, they'll sometimes put heavy metal in that gauze or band aid to prevent the growth of microorganisms. And this is usually used only on the skin because the heavy metal would be toxic taken internally. And it's a very good, I'm not sure if it's an antiseptic or disinfectant because it's keeping the bacteria from growing in the gauze and then also in the patient. So in that sense, it's an antiseptic. Any question about heavy metals? I've already talked about peroxygen, so let me move on. Phenolics was the first antiseptic that Joseph Lister found. He used phenol, actually. These are a little stronger phenolics, triclosan, creosol, hexachlorophene. They are antiseptics when they're used in low concentrations and disinfectants used in higher concentrations. Surface active agents include quaternary ammonium compounds, which are a disinfectant commonly used in hospital and other healthcare facilities. Any question about any of that? All right. The zone of inhibition size depends only partially upon the sensitivity of the organism to the disinfectant or the antiseptic. So the more sensitive the bacteria is, the larger the zone of inhibition will be. However, various other factors can affect the zone size, including the concentration of the chemical. The more concentrated the chemical, the larger the zone of inhibition. The molecular weight of the agent can also affect the zone size. The smaller the molecular weight of an antiseptic, the greater the size of the zone of inhibition. And the density of the bacteria inoculum can also affect the size of the zone of inhibition. The more dense the bacteria, the smaller the zone of inhibition will be. Evaluation of antibiotic effectiveness. Antibiotics are categorized as bactericidal if they kill a bacteria, and they're categorized as bacteriostatic if they inhibit the growth of bacteria. When we use a bacteriostatic antibiotic, the antibiotic will prevent the bacteria from growing, but will not kill the bacteria. Once you remove the antibiotics, the bacteria could resume growing. What we're doing is relying on the immune system to assist in the elimination of the infection with a bacteriostatic antibiotic. Any question about any of that? I used to know a bacteriostatic antibiotic off the top of my head, but I've forgotten what it is now. But I can tell you a biocidal one, and that is penicillin G, is a biocidal antibiotic. or a biocidal, bactericidal, same thing. Kirby-Bayer distaffusion test is the most common method used for antibiotic testing. So when a patient has a bacterial infection and the doctor doesn't know what to treat it with, or worse, the first drug he treated it with did not work, he can fall back upon the Kirby-Bayer distaffusion test to determine which antibiotic to use when treating a sick patient. Bacteria are isolated and then put on an agar plate, such that you have a lawn of bacteria growing everywhere on the plate. Before the bacteria are allowed to grow, you then put filter discs impregnated with various antibiotics on the surface of the agar. This will establish a gradient of antibiotic around the disc. You then incubate the plate for 16 to 18 hours at 35 degrees, and then look for a zone of inhibition where the antibiotic concentration is high enough, the bacteria will be inhibited, if not killed. Let me blow this up. So here we have a Kirby-Bayer distaffusion method plate to test the effectiveness of various antibiotics on this one bacteria species, which is coated all over the plate. And here you see these antibiotics have little, if any, that one too, although that one initially had one, have little, if any, zone of inhibition around them. So the bacteria will not be effectively treated with these antibiotics. That is known. And then we have some with a very large zone of inhibition here, and then some with a smaller zone of inhibition, like that one, and I guess that one. So which one should we use? Anyone have a guess? You don't know yet, because the size of the zone of inhibition can be how sensitive the bacteria is to that antibiotic. However, the zone size can be affected by other factors. For example, let's say this was a huge molecular weight antibiotic, and this is a tiny molecular weight antibiotic. Then because of the size of the antibiotic itself, meaning the molecular weight of the antibiotic, we would expect the zone of inhibition to be larger for this antibiotic than for that one. So the sensitivity cannot be determined from the size of the zone of inhibition. Any question about any of that? So the inhibition zone size is dependent on several factors. The diffusion rate of the antibiotic. A smaller molecular weight antibiotic will diffuse larger, creating a larger zone of inhibition. It can also be due to the sensitivity of the microorganism. A microorganism that's more sensitive to that antibiotic will have a larger zone of inhibition. And then the growth rate of the bacterium can also affect the size of the zone of inhibition. Let me see if I can remember this one. The faster the bacteria grow, I think the faster the bacteria grow, the smaller the zone of inhibition. Table 6.2 lists some of the, oops, get that out of here, I got the wrong thing. Lists some of the, I'm trying to shrink that, it's not shrinking for some reason. Oh, there we go. Lists some of the standard protocol for doing the Kirby-Bayer distaffusion method. First, you inoculate a nutrient broth using several bacteria colonies isolated on a non-selective media, and you grow the broth for less than 24 hours old. You then adjust the broth turbidity to 0.45 McFarland units. That's approximately 1 times 10 to the fifth bacteria cells per mil. You inoculate the plate at room temperature, but the plate is always using Mueller-Henton agar that is always between pH 7.2 and 7.4. A different pH can affect the size of the zone of inhibition, and a different media can also affect the size of the zone of inhibition. We also always use a agar depth of 4 millimeters because an agar plate that has more than 4 millimeters, the zone of inhibition will be smaller because the antibiotics will have more trouble diffusing through a deeper layer of agar. And then a thinner layer of agar, the antibiotic can diffuse further, so you have a larger zone of inhibition. And then you should always use a plate that's 150 millimeters in size. That's just one of the standard procedures. You should also use a non-sterile toxic swab to put the bacteria down on the agar plate, and you put the agar or the bacteria on the agar plate to get confluent growth of the bacteria on the plate, such that we call it a lawn of bacteria. And that's just referring to a lawn of grass where the grass is growing everywhere. You place the paper disc containing the antibiotic at least 24 millimeters apart from each other, no more than 12 discs per 150 millimeter plate. You then add the disc 5 minutes after you add the bacteria, but no longer than 15 minutes after you've added the bacteria to the agar. Meaning once you add the bacteria to the agar, you let the plate sit for at least 5 minutes. That's mainly to absorb the liquid that you put on the agar and then get the bacteria just established in location. And you don't want the bacteria to grow while you put the disc on before 15 minutes are up once you put the bacteria on. Any question about that part? You then take the plate and put it in a non-CO2 incubator for 16 to 18 hours at 35 degrees. And you put the plate in the incubator not more than 15 minutes after adding the antibiotic disc. So between 0 and 15 minutes after adding the antibiotic disc, you put the plate in the incubator. I'm not sure what the CO2 would do for the zone of inhibition. It may be species specific, but you allow the growth to happen for 16 to 18 hours. If you had less growth, meaning less time, the zone of inhibition may be, let me think about that, it may be larger. And if you have more time, the zone of inhibition may be smaller. You always grow the plates at 35 degrees. I'm not sure how that would affect the zone of inhibition. But they always standardize it, grow the plates at 35 degrees, not at 37, not at 30. I've never experimented with that, so I'm not sure how that would affect the zone of inhibition. Probably a cooler temperature. You'd probably have a little a little smaller. The bacteria growing slower. You'd probably have a little larger zone of inhibition if you were to grow at a lower temperature, and you'd probably have a larger zone of inhibition if you grew it at a larger temperature, hotter temperature, up to about 37. Obviously, beyond 37, you may have a smaller zone of inhibition. You may have no zone of inhibition if you don't get any bacteria growing. All right, those are the standard procedures for running the Kirby-Bayer disk diffusion method. And the reason for doing these standard procedures is so that you can compare your results wherever you are in the world with anyone else using the same bacteria and the same antibiotic disk, that hopefully you'd have similar, if not exactly the same results. Any question about any of that? All right. After the plates incubate, you then check for the sizes of the zones of inhibition, and you actually measure them, measure the diameter across the center of the disk in millimeters, and record that size. You then look at that diameter and compare it to the NCCLS table of standards. NCCLS stands for the National Committee for Clinical Laboratory Studies. And if the bacteria is Staphylococcus aureus and the antibiotic you're testing is penicillin G, if the diameter of your zone of inhibition is 20 millimeters or less, we say this bacteria, Staphylococcus aureus, is resistant to penicillin G. If, on the other hand, the diameter of the zone of inhibition is greater than 29 millimeters or equal to 29 millimeters, you then say the bacteria is sensitive, which is Staphylococcus aureus, is sensitive to penicillin G. Each species of bacteria and each antibiotic will have a different table of the standards determining what size determines the resistance and the sensitivity. And many of the entries in the table will have an intermediate, and that's the size between the size that is resistant and the size that is sensitive. So if Staphylococcus aureus has a zone of inhibition between 21 and 28 millimeters, you say that Staphylococcus aureus is intermediate to penicillin G. Any questions about how you determine sensitivity and resistance of a particular bacteria species to a particular antibiotic? All right, so know the terms of this lab. You can skip the references. While you're not going to be physically performing these activities, you will be held responsible for how to interpret the effectiveness of antibiotics using the Kirby-Bayer disk diffusion method. So in procedure 1, go ahead and view the video clip on how to prepare a spread plate. And then in 2, review the steps of using aseptic technique when preparing a spread plate or bacterial lawn of growth to do the Kirby-Bayer disk diffusion method. And this is so important, let me illustrate it. So pretend this is my petri dish containing agar that has no bacteria on it. And what you do is you get, gonna stick my pencil in there so I drink it. Can you guys see this? Can anyone confirm you can see these? You want to hold it in front of my face?
We can see it.
Okay, great. So pretend this is the cotton swab. What you do is you get a sterile cotton swab and then put it in the liquid broth. And before you take it out, you touch the cotton swab, I don't know if you can see this, to the edge of the tube to get the worst of the liquid off the cotton swab. The liquid, of course, has the bacteria cells in it. And then you take the agar plate and you smear the cotton swab all over the agar plate to get bacteria to grow everywhere on the agar plate. Hopefully you can see what I'm doing. I'm going at an angle so you can see this. And then the first time you do it, you take the cotton swab and turn it a quarter of a turn. Hopefully you saw that. You take the plate and you turn it a quarter of a turn. And then you repeat the streaking. Streaking everywhere. I'm going to skip it a little bit, make it a little quicker. And then you take the cotton swab and you turn it another quarter of a turn, and you turn the plate another quarter of a turn. And then you streak again. I'm going to have a hard time doing it this way. It's trying to show you and the angle and have it just isn't working well. I'm holding it at a funny angle. And then you take your cotton swab, and you may have noticed that when I occasionally went there, I may not have gone all the way to the edge of the plate. You take your cotton swab, and then you move it around the edge of the plate to make sure you get bacteria growing everywhere on the plate. I once had a student who what she did was she did something like this. Doop 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 doo. Doop 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 doo. And then she put her disc on and she tried to measure the zone of inhibition, and she had such poor growth on her plate, like there'd be a streak here and a streak there, and maybe a streak there, but in between there'd be this large area with no bacteria. She couldn't measure the size of her zone of inhibition. And I told her, well, you didn't put the bacteria on the agar plate correctly. So you either have to repeat this experiment to get your results, or you can use the data from your lab partner, because your lab partner put the bacteria on the plate everywhere. You're supposed to get the bacteria growing everywhere, what we call a lawn of bacteria. And then you can easily measure the zone of inhibition. So you put the bacteria on that way. You then let that sit for at least 5 minutes, and no longer than 15 minutes, and then you put the paper disc on the plate containing the antibiotic um, chemicals. And then before 15 minutes are up, you put the plate in the incubator. You should put it in the plate upside down, which I'm saying this is the auger. So it's going in upside down. And the reason is that you don't want the droplets to drop down onto the plate. And then you incubate it for 16 to 18 hours. That's the correct procedure. Actually, in the microbiology lab, we always did overnight because 16 to 18 hours would not be from class to class. Come to think of it, actually, overnight wouldn't be either because we did Tuesday, Thursday. What happened was someone would come in and pull the plates after a day and then put them in the incubator, in which case they may have done it 16 to 18 hours. And you put the cotton swab in the container containing biocide. Anyways, that's how you set up the plates. And then let's go to the worksheet now. The worksheet for Lab 6, we have a procedure for evaluating antibiotic effectiveness. So view the following video clips. We have a video preparing a culture for Kirby-Bayer diffusion test, and then another video on interpretation of the results for the Kirby-Bayer diffusion test. So go ahead and see those videos. Then click on the link for the virtual lab. The program may take a little while to download depending on how fast your internet connection is. I have a pretty fast internet connection. And then click on Start. You can click on Description, Steps, Credits, but once you do that, you need to click on Start to get the tutorial to really run. And here you see a plate of E. coli, which is the white stuff, and then antibiotic disc put on the plate. And on some of them, you can find a zone of inhibition. What you need to do for this is Now let's do XXT. Yeah, let's do tetracycline. It's very easy. I was trying to do SIP, but it's not easy to get there, and I can't move this ruler any other way except that way. So TE, it looks like about 18 millimeters. 18 is intermediate. If you get the right answer, it'll be green. If you get a wrong answer, it'll be a red X through it. And the X will go away so you can do it again, like streptomycin. Oh, I guessed right. Sorry. Penicillin G. I just guessed that right. I didn't mean to. Penicillin G. There we go. So let's say penicillin G is greater than 17. That's wrong. 14 to 16. That's wrong. And I can see it right there. There's nothing for penicillin G. So that's why it's less than 13. So you do that to get the answers. You need to do the virtual lab to answer one or two of the questions in the worksheet. So make sure you do the virtual lab. And this is the first bacteria. Let me bring that back here. The first bacteria is E. coli. To get the other bacteria, click menu and then click restart. And it takes the second page. That's Pseudomonas aeruginosa. And for TM, let's go ahead and do the about there. So maybe 18 TM. So it's greater than 15, so that's correct. So go ahead and do that for Pseudomonas aeruginosa, and then hit the menu again because we've got 3 plates here. Hit restart, and there you see Staphylococcus aureus, and you'll note that only one antibiotic has a zone of inhibition, and that's vancomycin. The zone of inhibition is about 16, 17, which means it's sensitive, and all the other antibiotics, this Staphylococcus aureus is resistant to them. So this Staphylococcus aureus is probably MRSA, multi-drug resistant Staphylococcus aureus. And vancomycin is one of the few drugs that many, not all, MRSA or multi-drug resistant Staphylococcus aureus is sensitive to. Any questions about any of that? And yes, some MRSA are resistant to even vancomycin. All right, that's it for the virtual lab. So let's go to the questions of the worksheet. So you're first going to be doing the Kirby-Bayer disk susceptibility test using E. coli as your bacteria, and then testing it against 4 antibiotics, ampicillin here, cephalofithin here, gentamicin there, tetracycline there. And then you're going to measure the diameters to the zone of inhibitions around the different antibiotics, and then compare that measurement to the standards in the table from NCCLS, the National Committee for something else, something standards, I think. Don't remember what NCCLS stands for. I'll do the first one for you. So here's the table for E. coli. If ampicillin is less than or equal to 13, it's going to be resistant to E. coli is resistant to ampicillin. If it's 14 to 16 millimeters in diameter, then E. coli is intermediate to ampicillin. And if the zone of inhibition is greater than or equal to 17 millimeters, then E. coli is sensitive to ampicillin. So let's table the standards. Come and do the table here. So we have, oops, I got that from last time. Let me erase that. So we have the zone of inhibition For the first one filled in, I'll do the interpretation for you for ampicillin. So let's go up here just to confirm that it's 15 millimeters. Let me blow this up a little. Come on. Oh, there we go. So you use the calipers to get your diameter of the zone of inhibition, and the dashed line is the zone of inhibition. But you don't read from here to here, which would be a little less than 10, because see this part here? The calipers don't have the 0 set to this one here. The 0 is set to here. So you need to read 0 to 0, and that means that ampicillin, the zone of inhibition, is just a hair less than 15 millimeters, meaning 0 to essentially 15. And that's why I've got 15 in there. And when you come up here, take a look at where 15 is for E. coli against ampicillin, and it's in the intermediate column. So the correct answer is I, or you can write intermediate right there. So that's the first one for you. Go ahead and measure the zone of inhibition for CF, GM, and TE. Put it down here, and then put the interpretation. Any questions about any of that? All right, for question 3, list 5 variables that must be standardized when performing antibiotic susceptibility tests using the Kirby-Bayer disk diffusion method. And you can get that directly from the table or from the text of the lab module. 4, what's the size of zone of inhibition often varies for 2 different species of bacteria when they are challenged with the same antibiotic. What is a possible explanation for these differences? 5. What would happen if we didn't use a septic technique to put antibiotic disc on the plate? And then mention what will happen to our test results as well. 6. What would happen if we increase or decrease the concentration of the antibiotic in the disc? Be specific in your answer. So here, we have a certain concentration, which I can almost read that. It's probably 30, meaning 30 units of ampicillin are in the disc, if I'm reading that correct. I might not be. Somebody might have better eyes than me, and you can read that. So what would happen if we put more antibiotic in the disc? And then what would happen if we put less antibiotic in the disc? So tell me in the question. 7, antibiotics can be called bactericidal, that is, they kill the microbe, or bacteriostatic, that is, they inhibit microbial growth but do not kill the bacteria. Remember, if you're using a bacteriostatic antibiotic, you're relying on the host immune system to remove the bacteria from the host, at least until the time or after the time you remove the antibiotic treatment, meaning you have to have the host immune system kill the bacteria while you're applying the bacteriostatic agent. Because once you stop applying the bacteriostatic agent, any cell that's left alive will now resume growing. When observing a zone of inhibition around the disc, how would you determine whether the antibiotic causing that zone was bactericidal or bacteriostatic? Like right here with ampicillin, is the zone of inhibition bacteriostatic or biocidal? What's the other one? Sorry, I'm losing my mind. Bacteriostatic or bactericidal? This is a difficult question to answer. It requires some thinking. I'm not sure if you can read about it in the text, but it is not, at least in the lab manual. but you should be able to get the answer. And many students miss the first time, but most students get the correct answer on the second time, turning in the lab. So just think about it. Once you get it, it'll be very easy. All right, 8. When performing antibiotic sensitivity testing, it's important that the test conditions are kept very standardized, meaning we use the same kind of media, the same agar depth, the same age of the culture. Why? Explain why. 9. Are there other substances besides antibiotics we could evaluate using this method? They're talking about the Kirby-Bayer diffusion method. And besides saying yes or no, you must name one substance, a substance. 10. Does the presence of a zone of inhibition necessarily mean that the bacteria being tested is sensitive to that antibiotic? Explain your answer. 11. From the size of the zone of inhibition of chloramphenicol on E. coli in the virtual lab, is the bacteria sensitive, intermediate, or resistant to the antibiotic? For chloramphenicol on Pseudomonas aeruginosa, is the bacteria sensitive, intermediate, or resistant to that antibiotic? All right, it's 7:19. I will be here until 7:45 to help anyone with questions. If you have a question, make sure you ask it before the last student logs out, because once the last student has logged out, I'm going to log out as well. Any questions? If not, go ahead and get started with the lab.